First of all, thank you for inviting me to talk with you about vacuum pocket cleaning, which is, I think, a promising addition to the treatment protocol. Yes, it will be next year that I'm 40 years a dentist, practicing a dentist, and of which I think it's 35 years in implant dentistry, which is a challenging field in dentistry. It is a very nice addition to what we can do in dentistry as if you look to reconstruction of severe cases and several possibilities we have. But first of all, I think we have a very large responsibility into what we do as a dentist and as an implantologist, because we are placing implants. I shall try to maybe, just a moment, I'm stopping here because I'm going to remove this one as well, because then you can see the whole presentation, I guess. Sorry for that. Yes, we have a responsibility in what we do placing implants, because we know after several years that we also we give patients also a potential problem if you look to peri-implantitis. And as we look to more and more to the way of how we look to perio and implant diseases in general, we saw the last 2 years ago that the perio part in our occupation is looking towards perio problems more and more as an immune problem, and I'm not sure whether Victoria Sampson talked about that or Irfan, because I stepped in a little bit later. Sorry for that. But I will talk a little bit about that as well. So let's see where we are into. If you look to my presentation, which will be in peri-implant health and disease in general, and of course Irfan talked a little bit about that, so I can skip something about that. Then we have current treatment methods for peri-implant disease. Vacuum pocket cleaning as a treatment for peri-implant disease. Then pocket cleaning in our clinic, what we do with the Flexion device, and then we might have some discussion, and we have some references. If we look to peri-implant health, well, we can look to it as Irfan also said, yes, we have the sisters system from Klaus Lang and Heitz Mayfield from 2000. And they revised it a little bit, and we know this schedule a little bit from the perio diagnostics. So if you look to peri-implant health in general, we look to absence of erythema, bleeding on probing, and swelling and suppuration. That's what we can look to from a clinical point of view. Then we have methods used to detect presence or absence of inflammation. So we have the visual inspection, probing, palpation, and enzyme tests. Well, and prevention is very important in this stage if we look to peri-implant health in general. So what can help us to look at the health if we use the IDRA system from Klaus Lang? If we look to peri-implant mucositis, and Irfan also talked about that, so that's not really something to go into detail, I guess. We see bleeding on gentle probing, which will like 25 grams of force, erythema, swelling, and suppuration, or suppuration, and the main etiological factor is plaque. The risk indicators are plaque, host responsible to bacteria, smoking, diabetes mellitus, and radiation therapy. If you look to the histology, you can see it here on the right side of the screen. We get an inflammatory infiltrate lateral to the junctional epithelium, infiltrate rich in vascular structures, plasma cells, and lymphocytes, progressive loss of collagen structures, And we have infiltrate does not extend apical to the junctional epithelium to supracrustal connective tissue zone. So most of the time we see in peri-implant mucositis that the bone is not affected. The treatment objective will be biofilm removal, and maybe I can a little bit reflect on what Irfan says, because topical application of something like Blue M gel, which is a very nice and very good way to treat those cases, is very promising, and I use it as well, and is the best we have. And I agree that it might be the last resort to do so. And you showed also cases here, Van, that we also can use that by doing open flap surgery and do it like and use it in the stage 3, like peri-implantitis with bone loss. And that's also a very good way to treat them. But maybe later on we might think about something to use before that, and to prevent all those kind of more difficult ways of treating peri-implantitis. So if we look to peri-implantitis, we look to the mucosa and subsequent progressive loss of supporting bone in comparison with the mucositis, the peri-implant mucositis. So the clinical characteristics are as like peri-implantitis mucositis, but greater pocket depth and apical migration of the marginal gingiva, as we all know. Radiographically, we see bone loss, and the main etiological factor is plaque. And risk indicators: periodontitis, poor plaque control, no regular maintenance care, etc., etc. We have data on smoking and diabetes that risk indicators are yet inconclusive, but albeit most appeal to common sense. Yes, stress is also a risk factor and risk indicator, as immune fitness, as we look to as we told before. If we look to the histology, then we have a dominance of plasma cells, macrophages, and neutrophils. We have apical extension of junctional epithelium. We have activation of osteoclast via rank and rank ligand. With resorption of alveolar bone. That is the most prominent difference if we compare the peri-implantitis with the mucositis. The treatment objectives are biofilm removal, decontamination of the implant surface, and how very difficult that is, showed Irfan as well, creating a cleanable situation, and to hope at least for re-osseointegration. If we look to the current treatment methods we have in peri-implant infections, then you can maybe divide that in 4 phases. Like first, the systemic phase, which is control of systemic diseases. The hygiene phase, optimization of oral hygiene, and yes, we can also look to that in a way of lifestyle changes, and lifestyle and immune fitness are related very much together, I am convinced. And more we look to peri-implantitis as something we might not always be able to treat it as a dentist. And we have to look a little bit different into dentistry than only looking towards teeth. The corrective phase, and we have that on a non-surgical and a surgical, and I think that is extensively covered by Irfan. And of course, we have the supportive phase, the maintenance phase. Well, if you look to the peri-implantitis, then the non-surgical and the surgical phase, as we saw, we have some of the issues. Well, if you look to the non-surgical, what is the golden standard? We don't know. If we look to the treatment of the implant surface, it is very much depending on the type of surface we have. Yes, we can use curettes and ultrasonic, but we know that we have titanium nanoparticles, and we might see phagocytosis. We have an airflow device, for example, is often described, but how deep does it clean? Does it? And we have a risk of emphysema. Chlorhexidine side effects after long-term usage, we all know, and it's not something we like to choose, but so far we don't have so much alternatives. And antibiotics is also a non-surgical therapy, but if we look to immune fitness, I think we might reconsider this. From the surgical way, we can divide it in a resective and regenerative way, as we've seen. But the questions are, what do we do in the aesthetic zone? A very nice case showed by Irfan, but what do we do in the aesthetic zone? Yes, we might need to remove the implant and start all over again. Regenerative, yes, this is a difficult procedure and a lot of requirements. It is expensive, and how predictable it will be. So there are a lot of questions, and I was happy to be shown the fluxion device, and well, it gives us the pocket irrigation based on the flux, and that's a novel device designed to irrigate the peri-implant pocket. So it's a rapid alternating infusion and suction, which will cause a flux. And the infusion is like a low pressure liquid infusion, and the suction is vacuum and creates under pressure in the pocket. So for that you have the flux. The result will be a sulcus fluid is replaced by the liquid of choice. And that brought us in our clinic to think about what we could use in the fluxion, but I will talk a little bit on that later. Well, the potential advantages of the fluxion device will be that it is non-invasive. So it's solely fluid dynamics in the pocket. It's no impact on the implant surface. Yes, we can do a deep cleaning up to 9 millimeters. And I think with just a gel or topical application or chlorhexidine or just brushing, as in periodontics, we know that periodontal cleaning or just I should say, mouth brushing, tooth brushing will not influence the bacteria under the 4 millimeter of pocket depth. So, and the fluxion is a potential, has the potential to do a deep cleaning there. So it can replace the peri-implant clavicular fluid. It can cause a disruption of the biofilm by removing the parts of the biofilm, bacterial substances, and exudate. If we use, for example, a Blu-M oxygen, sorry, we come to that later. If the oxygen suppletion, for example, if you use the Blu-M, then it stimulates self-healing capabilities and reosseointegration, which is still a question mark, but it has a potential to that. And of course, if we look to patient comfort, it is a pain-free treatment and it has no aerosols. So the addition to the fluxion, we start on thinking, well, if we have the fluxion and it has this the mechanism, why shouldn't we take another fluid like Blu-M mouthwash? So this is what we started to do. And I don't have to add something about Blu-M because Irfan just already talked about that and pointed out what are the substances of the Blu-M mouthwash and an oral gel. So it can be used as a liquid in the fluxion, and it can give us an enhanced disruption of the biofilm compared to demineralized water. That was something we started to think about and wanted to research. So that is basically what we did, and I'm not sure whether you showed all
Als ik het zo mag samenvatten, dan zou.
I'm not sure whether you discussed this already, but when we use the fluxion, and you can see here what we did with one of the cases, you see clearly how the device works. It gives like a flux, and you can see that here, like a pump working. And if we supply Blu-M mouthwash, we thought it could be a potentially contributing to the working of the flux itself. So if we look to the pocket irrigation in the Oosterwijk Clinic where I work, we had three components, three stages of the experimental approach we work with at the moment. The first component is like the scientific research we do and we set up. And the second component is the experimental cases I will talk about a little bit. And the third component is the daily application. And where can pocket irrigation with Blue-M contribute to the standards of care we have at the moment. First of all, the scientific research. We set up like a research, and we did this with the Groningen University of Dentistry. The student is a very talented student, Miran Mir, which is he's just only a very young potential. No, he's not potential talent. He's talented guy, and he set up the research together with this university, and the aim was to determine the effect of refluxion with Blue-M as a treatment of peri-implantitis. It is a randomized clinical trial, and we have like a number of 60 implants randomly distributed over three treatment groups. One we treat with fluxion and demineralized water. The second is the treatment group we treat with the fluxion and the Blue-M, and the control group is like the airflow, which we are quite familiar with. At this moment, we are in the starting phase, and we are waiting for the authorization of the Medical Ethical Committee of the university. And the timeline will be that baseline measurement, clinical and radiographic variables and treatment. And after 6 weeks, we do the post-measurement, and we look also to the clinical variables. And after 6 months, we do the post-measurement radiographic variables. The variables are the probing depth, active matrix metoproteinuria, the MMP8, which is a reflection of the patient's health, and peri-implant and periodontal health can be measured by measurement of the MMP8. Bleeding or probing, suppuration, plaque, and radiographical bone height. A little bit about MMP8, as I already said, I am convinced, we are convinced that the loss of bone around implants and around teeth has a very strong relationship with immune fitness. And yes, with how you live your life. But the last part you can not easily change. So, but we have to look at it. We can measure it. We can measure the amount of MMP8, and that is like a collagen-lytic protein. Is a chairside test by Implant Safe, Perio Safe. And it is to accurately determine the current state of the periodontal and peri-implant degeneration. It takes only 5 minutes, and it is a continuous result in nanogram per milliliter on a digital reader. And you see that on the right side of your screen. And the cutoff point we take is like 20 nanogram per milliliter. If you look to the experimental cases, we did a few extensive cases just to see how things were developing. We used the fluxion with Blue-M, and what are the clinical effects of one treatment. The documentation according to the scientific research protocol, and currently we have some severe peri-implantitis cases treated, and we saw a follow-up of 4 weeks. And yes, we have varying results. Let's look to the first case, very severe case, and it's an 82-year-old male, generalized oral complication, implant 3/6 treated, and a great improvement after treatment, yet inflammation and still present. If you look to the MMP8 measurement, as you can see in the lower part here. The second case is a 54-year-old female, implant on the 1-1. It's she had periodontitis, it's treated. She's recently stopped smoking. Yes, she's a stressful person, and we saw no improvement after treatment, and you see even a worse situation of periodontal and peri-implant breakdown. So that leaves us some of the questions. The 77-year-old female, implant on 1-4, the stressful person, generalized oral complications, and no improvement after treatment. The same thing here if you look to the measurement of MMP8. So that left us with a lot of questions, and the results are not yet optimal. And why is that? Well, I think we started with the wrong cases. If you look to the pocket irrigation, we started with severe peri-implant cases, which treatment will help. We are not yet comfortable with the cases we had so far. And the intended use of the fluxion was peri-implant mucositis instead of peri-implantitis. What we also saw, if we looked a little bit better to the cases, that there were many risk factors for implant diseases in the treated patients. And the next step will be the same patients, more intense protocol as described by Hentenaar, for example. So we are going to change our protocol and do that more frequently. If we look to the pocket irrigation in Oosterwijk Clinic and the daily use of the fluxion, nowadays that will be is done by dental hygienists and assistants. We treat peri-implant and periodontal treatments, and we have mixed opinions. The pros, mixed opinions by the dental hygienists and assistants. So it took a little bit of energy to convince them that it's the only thing we have if we look to proper pocket cleaning. And yes, if we end up in the severe cases we treated, you might have some less good results, so to say. The pros are the debris are clearly visible in the waste container, as you see on the right side. So you can clearly see it does something. It does, for sure, it works for the cleaning of the pocket. The treatment is a pleasant experience for patients. They don't feel anything. It's not painful. It's not too time consuming. So that's really a pro. The cons are, I don't feel it does anything. This is what one of my dental hygienists said. She was working most of the time with other techniques, such as just rinsing. And she felt that this does not do anything, and unless we look to the container on the right side. And it is a little bit difficult to handle, so it needs a little bit of training. So if we look to the possible applications in the future, then we can see, if we look to the 4 stages of peri-implant diseases, that it has a potential contributing factor in the optimization of oral hygiene, and to assess and to minimize the risk factors. It has a potential advantage and possibility if we look to in the corrective phase in the non-surgical way by remove the biofilm and decontaminate the implant surface. And yes, it has a potential advantage if we look to the supportive phase. So these are the references of what I was talking about. Again, thank you so much for being with me. I think I had to a little bit rush, but I think I'm within my 50 minutes. I hope so, at least. Thank you so far.